Okay.
All right. Good morning, everybody. I'm Dr. Sal Pacella, board-certified plastic surgeon from San Diego, California, and I'm joined this morning again by my two incredible colleagues, Dr. Sam Rhee from Paramus, New Jersey, and Dr. Sam Jejurikar from Dallas, Texas. Welcome to our podcast this week. I just want to remind everybody to jump on in on Instagram and check us out on our Instagram handles. You'll see a lot of before and after photos. You'll also see a little bit about our lives and some patient stories. Dr. Jejurikar is at Sam Jejurikar. I'm at San Diego Plastic Surgeon, and Dr. Rhee is at Bergen Cosmetic. So thank you very much for attending here. I'm just going to give a little short intro as a little hint about what we're talking about today. So excuse me just a second here. To hell with romancing. She's sweat wet. Got it going like a turbo vet. I'm tired of magazines saying flat butts are the thing. Take the average man and ask him that. She got to pack much back. So today we're talking about butts.
I could really tell you felt that. Like feeling. I mean, were you an actor? Because I felt that.
That was Shakespearean. That delivery.
It was fantastic. Just one more thing, folks. Once again, this show is not a substitute for professional medical advice, diagnosis, or treatment. The show is for informational purposes only. Treatment and results may vary based on the circumstances, situation, and medical judgment after appropriate discussion. Always seek the advice of your surgeon or other healthcare qualified provider with any questions you may have regarding medical care. Never disregard professional medical advice or delay seeking advice because of something in the show. So according to our intro, we're going to talk about butts today, the gluteus maximus region. And in dedication for that to my friend in Texas, I'm going to put this on here because this is everything's bigger in Texas. All right.
Is that an authentic Texas hat?
It is.
Okay.
I think he got it for free with a case of tequila. So
Very nice.
It looks good on you, particularly with the headphones. I like that.
Before we get into that, how was everybody's week? Busy getting back to business?
Yeah, well, I guess I'll start. In Texas, we're still pretty busy, but there's this impending shadow of us not being busy. Coronavirus cases in this area are definitely surging. The hospital capacities are getting very, very full. And it's within the realm of possibility that if we don't see it diminish in numbers, things could definitely start to slow down again, either externally driven by the government or just patients being fearful.
Yeah, I think nothing has changed in New Jersey for us, and they were supposed to have liberalized restrictions, and they have not, mainly because they see what's going on in other states. New Jersey is probably one of the few where the R value, which is the number of infections caused by every infected patient, is actually less than 1. But because of the fear of other states, they've started mandating all these quarantines for people traveling from other states into New Jersey. I don't know exactly what they're going to do because I feel like the pandemic's going to continue to rise. And if everything stays okay in New Jersey, a lot of small business owners and people are going to probably put a lot of political pressure on our governor. So, I mean, for me, things are good. I'm busy, haven't had any issues, but I think things are going to probably change, like Sam said, pretty soon.
Mm-hmm. How about you, Sal? What are you guys seeing in California?
Well, there's definitely a surge of new cases. We are still doing widespread testing, and I think that's helping with the general control of things. But I'm just waiting for the ball to drop. I think we're going to have probably a reduction, I think, soon, and reduction in cases and probably access pretty soon, I think, depending on what's going to happen this week. It's been about 85. People are hitting the beaches. It's been, there's virtually minimal social distancing going on. So it's been a tough week, I think.
Are you still surfing?
Mm-hmm.
Okay, well.
Went last night and going to go today again.
All right.
Nice.
So there's a monster swell, bro.
Well, on that note, let's switch to butts. I'm going to see if I can share my screen here. I'm
going to take this off.
Let's see. I apologize for this. You guys carry on while I figure this out here. Let me open this presentation.
I have to say, every time we start presenting bodies and pieces of bodies or parts of bodies on our show, I freak out a little because I always worry that Facebook or YouTube is going to stop the broadcast. They're very uptight about stuff like this for some reason.
Can you guys see my window here?
Yes. Yep.
And all I see is my presentation. Do you guys see each other's faces and all that? It doesn't really matter
yes.
if I.
Yeah, we see you as well. Yeah.
Perfect. Well, with that awkward transition, I apologize for that, everyone. Let's talk about butts and where we're at in 2020. So, just want to draw the other guys into this a little bit as well. Brazilian butt lifts, I think, are still a very popular operation in our society and in my practice in particular. And it's probably the procedure most likely for people to pull out their cell phones. And what I mean is I'll come in, I'll ask people what they want, and they whip out Instagram and they start showing me pictures. And these are all examples of pictures I've probably seen in the last few weeks. Have you guys noticed this sort of phenomena as well?
Yes, only with butts. People will always pull out Instagram pictures and say, this is what I'm looking for. They might be 5'1" and 275 pounds, but they'll pull out that picture right there and say, that's my goal.
Yeah.
Yeah. And this is just a testament to the regional variations we see in patient populations and styles. I've actually never had a patient whip out a butt picture like that. It's
really,
yeah, it's surprising. The community and region I'm in is fairly athletic, fairly fit, and it's just not an aesthetic that people are coming in and asking about, interestingly enough.
What I'll say is I see all different body types, all different wishes, and it's tough because as Sam, Jersey Sam, already alluded to, it's really difficult to take a butt from one person and make that result on somebody else, and so it's setting expectations is a big thing. So I want to talk a little bit about where we're at in 2020 because gluteal augmentation is an operation that's had a lot of controversy, particularly over the last 4 years. I think I would say in my practice, 2016, 2017, it was among the biggest operations in my entire practice, if not the biggest. Then a lot of really alarming things started coming out from across the world. 2016, there was a big paper out of Central America that showed that in the Dominican Republic and Mexico, the death rate may be surprisingly high. Following year in the US, there was a big paper that came out in our aesthetic surgery journal that showed that the death rate could be as high as 1 in 2,350, which got everyone's attention. And I'm sure you guys remember this, but it seemed like every other week we hear news stories about somebody dying from the operation, oftentimes out of Miami, it would seem like. And so there were calls across the world to ban the operation. In Great Britain, the British Society of Plastic Surgeons actually recommended it not be performed. In the U.S., there was some talk about that, but instead, what happened? There were a variety of task forces that were out there, and the biggest one was the Gluteal Multi-Society Fat Grafting Task Force, which Peter Rubin out of the University of Pittsburgh chaired. And I was lucky to be one of the members of that. And there was a lot of healthy debate among surgeons that did a lot of these operations. Ultimately, the recommendation came out that we needed to change the way we were doing the operation. Where previously we had focused on injecting deep and injecting superficial, we found that if we injected superficially, we could avoid traumatizing some big blood vessels, which I'll show you in a second here. And by doing that, we could do it safely, not traumatize these blood vessels, not shower fat into the body to cause something called the fatal pulmonary fat embolism, and do it very safely. So a paper that just came out a couple of months ago is now showing that the death rate's actually much lower now, and it's along the lines of about a tummy tuck, which is considered to be a relatively safe operation. You have anything to add to that, Dr. Rhee? Are you ever injecting deep at this point?
No, and I do remember when your task force findings came out, I actually was at the meeting, the ASPS meeting that year, and it was super helpful. They, some people did cadaveric studies. They had some very, very good photographs, and it showed the technique that we needed to do to avoid problems. And I thought it was one of the few, I mean, I don't want to rip on our society, but it was one of the things that I felt was very helpful from our society.
Yeah, and I think it's an important thing to understand too. You know, we again, for the patients out there listening, you want to really do your homework when it comes to choosing a plastic surgeon, particularly a board certified plastic surgeon. For this technique, you don't want somebody that is just doing this as a hobby. You want somebody like Dr. Sam in Texas or Dr. Sam in New Jersey that is experienced in this. You know, these types of procedures, although they may seem very minimally invasive, we're making small cuts. They're minimally invasive, but can have maximal effect. And so that's exceptionally important. We have to understand as plastic surgeons, when we're making small cuts, we're going down deep into structures. I don't do a tremendous amount of Brazilian butt lifts, but I do a lot of fat transfer. And it's important for me to understand how deep I'm going in the face. There are arteries, there's eyes, there's blood vessels, there's breast implants in the breast when we're doing things. So this is of critical importance. So my kudos to Dr. Sam for attempting to improve the specialty with that task force. Wonderful.
I was certainly not the main voice in that task force. Let's not overemphasize my role, but it was a privilege to be part of it for sure, and to just hear some of the brightest minds in plastic surgery, how they think and how they all sort of came together. And so can you guys see my mouse? Do you see this here, or do you not?
Yes, it's very small, but go ahead.
Okay, so basically, I'm just trying to point out to our viewers what we're even looking at here. This is if you're not trained to look at MRIs, this could just be a pile of mishmash here. But what you're looking at here is this black space on the very bottom is outside of the body. And what you're looking at the very edge of the black space and the bright white is your skin. This bright white layer is the fatty layer. And this is where our butt normally sits. And so if you think about it, it makes entire sense to inject fat into this area. This is, after all, where our butt actually is. And so when plastic surgeons are talking about injecting superficially, this is what we're talking about. I used to give a talk, which I've given at the American Society of Plastic Surgery meeting and other places as well, where I would talk about safe, deep injections, where we would inject deep in this area here to try to give a foundation. 2017, I stopped doing that, largely because of these task force proceedings that were going on. And I basically found once I stopped doing that, my results didn't really change. I couldn't make the butt as big, which is difficult from a patient expectation standpoint. But if I stayed to this area, I could reproducibly create a very nice result for people. What you're looking at here in this diagram is all of these are the gluteal muscles in blue right here. And the vessels that we're talking about trying to avoid are hidden down in here. So you really have to make a concerted effort to inject deep into the body to get those vessels. So the take-home message from this is, if your surgeon knows what they're doing and they do a high volume of these and they know to stay superficial, they should be able to stay superficial. The other thing, this was from a presentation that I used to give a lot. This is where the vessels are located. When we inject from the bottom portion of the buttock, which is the only area that where it's kind of easy to slip deep, it's important to stay lateral. And you'll see here in this next view, like when we're actually injecting, you can see the tip of the cannula the whole time. This is fat that's been collected via liposuction. And then I collect it in a canister and we just go ahead and inject it. And I had all these great pictures of fat harvest, but I was afraid because it showed too much of the human body, it would be blurred out by Instagram. So I apologize for not showing that. Just out of curiosity, when you guys do fat transfer, what's your technique for harvesting fat?
So, there are various devices on the market, and I particularly like the PureGraph system. I think it's one of the higher volume systems. When I'm using this in the breast, when I'm doing fat transfer in the breast, I need a fairly large volume, anywhere from 300 to 1,000 cc's of fat. And so the PureGraph system, in my opinion, gives a good yield. There's a lot of tissue that can be utilized from it. It's a little bit of a learning curve for the OR staff and the techs, just because it has to. The system's a little bit bulky. If I'm using fat transfer in the face, I'm not really using that much volume, probably 20 to 50 cc's max. And I just use a little hand harvest device, rinse it manually, and just place it on a small telfa to get off the fatty component, or the viscous component.
So with the PureGraph, how are you taking the fat out of the body cell?
With liposuction, power assisted liposuction. Yeah.
Okay. And what about you, Sam?
I use a power assist system too, and it goes directly into a sterile Wells Johnson canister, basically.
Same way. Yeah, I do similar to that. Yeah.
Are you using any commercial device, Sam? Texas Sam? Tell me a little bit about your fat preparation, like what you're doing.
So it's similar to what Sam Rhee just described. I'm using either standard or power assisted liposuction to collect fat into a canister made by the company Wells Johnson. It's a 5-liter canister, which is basically corresponding to the amount of liposuction the American Society of Plastic Surgeons tells us we should do in a case. It's sitting on a little vibration platform, which allows separation of the fat from basically plasma. You can passively drain off the plasma. I'll go ahead and wash the fat once with saline and some antibiotics. I use clindamycin and gentamicin in my solution. Go ahead and let it separate some more from that fluid, and then I'm ready to inject it using a peristaltic pump, which is what you see in this picture right here. So no commercial products, just the same piece of equipment. So I'm going to go back to this picture that we had before, because in the beginning I was using this picture to try to demonstrate what it is, just the way a consult traditionally goes and how challenging it can be. The other thing that I'll say is some of these pictures are really large butts. I think if you were to look at the one in the bottom left and the one in the central portion of the bottom right here, these are difficult results to achieve. So Sam Rhee, when you have a patient come in and they show you this picture and this butt is this big, what's your approach? What do you tell them?
Well, I used to, at the beginning of my practice, get a lot of these types of patients. And now, as I have developed a practice and sort of not a following, but people know me more in my area, they know that this is not something that I wish to achieve, nor can I sort of achieve in a lot of the patients that I see. I think some patients I can achieve this, and I'll let them know if I can, but in a lot of patients it's unrealistic. And usually if I do see a patient like this, I will tell them it's not going to be one procedure. It might take multiple to get something close to this. And this is not just achievable through surgery alone. This is only achievable with a lot of effort from the patient in terms of what they do in their lifestyle and their fitness and nutrition choices. And, if you look at these patients, or not patients, these Instagram models, I see a lot that's just not realistic. I think some of these are flat out altered images that are digitally altered and not real. And I have to point this out to patients. I don't know. I'm seeing less of this personally, because I think patients who realize that this is not something that I feel is reasonable, or they're not coming and seeing me as often, but it's still something I encounter every once in a while.
You said a couple of things that I thought were interesting. Yeah, we have to definitely be wary in the era of Facetune of digitally altered photos. I don't really have a good way of knowing which are digitally altered or if any of them are, but many photos that are out there clearly are. And then you talked about fitness and nutrition choices. And the thing that I struggle with the most, and I'd be curious to hear Sal Pacella's thoughts on this as well, is we're using fat as a filler. And if you think about it, fat in most aspects of our life is an undesirable tissue. The way we eat, the way we exercise is sort of geared towards getting fat to shrink from our body, yet we're trying to use it to achieve volume expansion. So what do you tell patients after surgery about, okay, what do you need to do from a diet standpoint, from an exercise standpoint? How can you expect your fat to respond to changes in weight, changes in metabolism?
That's an excellent question. So I think the important thing I tell patients many times is, just because I'm taking fat from your abdomen and injecting it into your breast or your face, that fat doesn't forget that it comes from your abdomen. It's actually different fat than facial fat, right? Mm-hmm. So I counsel patients that if I'm doing a facelift or a blepharoplasty and I inject, a few cc's of fat into the eye or the cheek area, and the patient gains 20 pounds, this is not going to look great, because what's going to happen is this is going to puff up. It's going to be very unnatural looking. So your weight has to be stable. When I do it in the breast for, say, an implant issue or for breast cancer, many women are fairly thin going into this, and they may want to maintain their weight or lose weight or gain weight or whatever. And the important lesson I tell patients is you want to be at your most stable weight, because that fat is going to do what it's going to do based on your overall metabolism. So in general, I try to overcorrect things a little bit, at least when I'm in the breast area, because I know some of that fat's going to resorb. I know patients may change their weight volume. And it's important for us to understand not only the three dimensions of where we're putting it, X, Y, Z, but the fourth dimension of time, what's going to happen after that.
Yeah, I agree with that. I'll tell patients things very similar to it. And as Sal kind of alluded to it, I think a certain percentage of fat dies in every fat grafting case that we do. I'll generally tell people that when I do a Brazilian butt lift, I expect if they do everything perfectly, I make them stick to a high calorie diet during that period of increased metabolism after surgery. I make them avoid pressure on their butt for several weeks after surgery, both when sitting and laying down and with the clothing choices they make. And I tell them if they do everything perfectly, they'll still lose, if they're lucky, about 40% of the fat. And to me, that's a good result.
Tell me a little bit about the high calorie diet. What's that about?
So it's my general thought process is this. As you guys know, after surgery, we have a hypermetabolic state. Our body's trying to heal all of the liposuction sites that we're doing when we do a Brazilian butt lift. Our body's trying to heal these new fat cells that are actually there. And if your body doesn't have calories that are easy to mobilize and easy to use, it's my thought process that they're going to start breaking down fat. Fat that's, in my experience, that's been easier for them to mobilize is the fat from their buttock. And so I'll notice a precipitous drop in fat or buttock size in patients that aren't sticking to a high calorie diet. And it's a tough proposition to get patients to accept. People are having liposuction to shape their body. They're very much afraid that if they're going to eat high calories after surgery, they're going to get fat. So what I've negotiated and I found to work pretty well over the years is 4 weeks, 2,500 calories or greater a day, but it's got to have some simple carbs in it. It can't just be, a keto diet or something like that. Mm-hmm. Do you do anything like that, Sam Rhee?
No, that's so interesting, and it's something I may consider, actually.
Is there any data behind this, or are you this is just your overall?
I think there's a lot of people
experience.
A lot of people that do it. I don't think it's been studied formally, but I've definitely can literally tell when someone's come into for their post-operative appointment, if their butt is smaller than we would expect, that's the first place we go, and very often that's the culprit behind it.
That's a great idea for a study for one of your fellows there, Sam.
That is a great idea. So this is what I think is a good result from a Brazilian butt lift, from just one of them. I will describe it to people as being a shape-changing operation more than a buttock size operation. If they come into me and they say, Dr. J, I love my body shape, I love my butt shape, I just wish you'd made it a little bigger, to me that's a perfect result. Because you can only work with what you're given. You're limited by the tightness of the buttock skin envelope. you're limited by the amount of available fat. But you can see in this patient, when you do liposuction of the lower back and love handle area, particularly this hollow right in the central back right here, you can start to create a shape to the body. When you do liposuction of the tummy, you make their body, their waist to hip ratio just better overall. And then you can add fat in a way that adds projection, adds roundness, adds size, adds fullness across the sides as well. But it's not huge. Like it's not distasteful. This is what I would consider to be a good result with one Brazilian butt lift. And these are other ones that are going to be like this as well. You're going to notice a similar aesthetic to a lot of the patients that I do. Really sort of focus on trying to deepen the waist, create curves to the body that are not right there. But these aren't huge butts. This is literally the most you can do with the amount of fat that you have. Same sort of thing in a patient that has a little bit more fat. You can achieve a little bit more roundness. A thinner, more athletic patient, you're going to achieve a little bit less, more of an athletic shape when they're done. And then, as you, but the key thing is people will come in a lot of times and they'll say, Dr. Jejurikar, I'm really, really concerned that you're going to make my butt too big with one operation. It's pretty hard to do. Not that I'll say that it's impossible, but it's pretty hard to do. More often than not with one operation, because of the amount of fat that you're losing, it tends to end up being relatively out of proportion, but not too out of proportion to the rest of the body size.
So Sam, can you tell us, say for example, with this picture, how much liposuction volume did you remove? How much fat did you inject?
So I don't remember the specifics of this case, but I would estimate that the amount of fat removed is going to be between 4.5 to 5 liters. The areas that I do in pretty much everyone are going to be the abdomen, the love handles. In this patient, I did the upper back as well to kind of hit this broral area and try to get the skin to tighten. Looks like I did a little bit from the inner thigh as well. She has more of a gap than was there before. Of that, when I have 5 liters, by the time I'm done washing it and draining out plasma, we usually have around 2,500 to 3,000 cc's of usable fat. And in this patient, I think I probably used all of it. And that's divided between 2 buttocks. So, about 1,200 cc's per butt would be a good estimate.
And tell me a little bit about your positioning, where you start, how you position the patient.
So in my practice, we have just one intraoperative position change. We start off with the patient laying on their back or the supine position. We'll do liposuction of the abdomen and a portion of the inner thighs from the front. Then we actually, some people will do it as one continuous prep where they'll turn the patient sterilely, which requires the patient to be prepped standing up before they go to sleep, because I just don't think in my practice that's something I want to have to make patients do, get prepped and painted while they're standing up awake. We take all the drapes down, we turn them again to their prone position, so they're laying on their tummy. We use what's called a jackknife position, where basically their butt is held up in the air, which makes it really easy to angle your hand upwards while you're injecting. So you can inject superficially and feel really comfortable about the plane that you're in. And then we put the garments on them at the end of the surgery, which compresses all of the areas we did liposuction on while having holes cut out over the buttock. So there's no pressure on the buttock. And then they're turned to their side to have the breathing tube come out at the end of surgery, and they turn to their tummy as soon as they're widely awake. So I'd be curious actually to hear what Sam Rhee's post-operative protocol is for sitting, and what, how you guys would handle a large volume fat grafting case in terms of how you let people, recover.
Well, the first thing I want to say is these are cases that are exactly what I think BBL's procedures are made for. It's not to make something excessively or disproportionately large, but it works really well to help fill areas that are, say, flatter than the rest of the butt, say hip dip areas or the lower butt area. And it is so important to get that love handle area brought in, because that really does enhance the overall gluteal aesthetic. And I think all of these cases show exactly what an ideal BBL case really would be. These are not overly obese patients. They don't have a ton of skin excess, and they are all, to a reasonable degree, reasonably fit. And so I think these are great examples. For large volume fat transfer, I will usually put them in a binder with lipofoam first as a compression garment. I feel like there's a fair amount of edema, and every time I've stuck patients into a full length faja or compression garment, it tends to cause problems. I will give them a BBL pillow right from the get-go, and I'm pretty strict, or try to be, with my patients. I don't know if they're always complying, about avoiding pressure. It gets complicated for some patients because of work, but you can really see a huge difference for patients who are not complying with sitting and those who do. I usually will put them in a full-length garment, probably somewhere in the 10-day post-op period, and I do not mandate massage therapy for my patients, but I do feel for many patients it is of benefit. And so I do partner with some different therapists in the area and try to work out something where it really does help with edema reduction and just general sort of quality of life post procedure.
Yeah.
And, okay, go ahead.
No, please. I'll jump in after you, Sal.
Tell me, for both of you, how long would a case like this take you?
Well, for me, I mean, I know Sam is very efficient and he has a pretty, you work out of a surgery center. I'm sort of doing this. It takes me for a full lipo 360 plus fat transfer, maybe like 3 hours.
Yeah, I don't think I'm that far off from it. I'm not in a hurry when I'm doing this, so probably 2.5 to 2.5 hours to do this. Mm-hmm. I don't really feel like I'm rushing during it. I don't stack my schedule in such a way where I'm never in a hurry. So I kind of just take my time with it.
Now, you both are not spring chickens, right? You're not, you're midway in your career. And, this is a procedure that takes a bit of arm strength, right? So Sam Rhee, do you try to do this on leg day?
That's right. If I'm on arm day, I try to skip these and do something nice, like your little eye surgery or something like that.
Well, I mean that in jest, but tell me a little bit about like how you prepare for this. Obviously, I can say, I've had a disc herniation in the back, and I'm pretty cognizant of the way I'm standing. I sometimes wear a back brace when I'm doing a big surgery like this to avoid pressure on my back. This is obviously a tremendous amount of work you're doing back and forth for 3 hours. And so tell me what you do to protect your own body.
Yes, you hit the nail on the head. When I think
these are exhausting cases.
Well, I think in general, surgeons have not really looked at ergonomics and how we operate. And I think we've all seen old surgeons with a lot of problems, cervical problems, lumbosacral problems, So I do know that now when I do prep and set up for these cases, a couple things. The first is I always use power assist. I could never imagine doing this just manually because that would kill me with the amount of effort it would take. The second thing is I have a pedal, and I now know I need to alternate which leg I am using for the pedal, because if I'm sort of keeping to one leg the whole time, I will feel it. The second thing is I do keep the patient relatively close to me. But for all of my cases now, like if I'm sort of reached over something, I can feel it in my back in a huge way. So I try to position myself where I keep everything close. I am keeping everything at the right height for me ergonomically. And I think, like Sam said, positioning the patient the right way, the jackknife position, all of that is very helpful in terms of setting things up for yourself so that you are protecting yourself.
I do many of the same things Sam does. I totally agree with bringing the patient as close to you as possible. I think my strategy has changed a little bit. Although we do have power assisted available, I don't use it that much anymore.
Wow.
I actually do most of this with manual using basket cannulas, just because I personally just prefer the way my liposuction results are with that, but that's a very individual thing. I've gotten better about exercising in the morning before these cases, but I work out differently than Sam Rhee does. Sam's a big CrossFit guy, so you're lifting heavy weights. I tend to do a lot of aerobic exercise and stretching in the morning, which I have found has helped me quite a bit. So I used to actually, about 3 years ago, I was on the verge of getting a rotator cuff operation, but through physical therapy and some supplemental metabolic medication that I take, I basically feel great, and I don't have any joint breakdown at this point. So everyone has a different strategy, but for me, it's been stretching and aerobic exercise has really helped me quite a bit, and it's reduced my fatigue tremendously.
Yeah. I think I just simply don't know if there are any younger surgeons or residents watching this podcast, but I think one of the things we have to understand as surgeons is, obviously we're very highly educated, very focused on our career, but we don't understand really in residency or coming in that this is a very physically demanding job. That's beneficial because we're out there, we're moving, we're sort of using our bodies to help patients benefit their bodies. But it is a physically demanding job. And if you need energy, longevity, this is a marathon throughout your lifetime. And I can personally say that, the first couple of years after practice, I felt like I could do anything, stay for 10 hours doing a micro case in the same position. Now I'm exceptionally cognizant of what my neck and body are doing, particularly when I'm doing facial surgery. I'm hunched over like this. And it can be a difficult day. Your neck's sore, your body's sore, wearing loops is, taxing for your neck. And so it's important to listen to that biofeedback you have as a surgeon.
I completely agree with that.
Agreed.
That is very good advice for a younger generation. So I think with the cases that we've shown, I think it's obvious what we can do with one operation, but that doesn't satisfy everyone that walks in the door. So I'm going to throw this case at you guys and want to know your approach. This young lady walked into my office now about 4.5 or 5 years ago and said, "Dr. Jejurikar, I want to have a really big butt. I really want to have a big butt." What's your approach to this, Sam Rhee?
Boy, I don't know. I would tell her I don't know if this could be done with natural means. I just don't know. I feel like I'm only showing us. I don't want to show it too long because I worry a little bit about the ass crack.
I'm sorry. Yeah.
Oh, it's okay. I think
I'll flip ahead. Yeah.
Oh, okay. So I just feel like I would have a really hard time achieving this naturally, and I would tell the patient that I don't know where I would get the fat from.
So that's very right. So this is the patient about 4 weeks ago on the right. So on the left here, pre-op. On the right, post-op. So this was about 5 years ago, and this was now. And this took me 2 operations to get to this point. First operation, exactly what Sam Rhee said. You can't do this with fat alone. I use a technique which has been really popularized by Dan Del Vecchio in New York City, called much like in breast augmentation, we have dual plane breast augmentation. In Brazilian butt lifts, we also have dual plane. I'm sorry, Dr. Pacella. Okay. So we have dual plane buttock augmentation as well in gluteal augmentation. So what we did in the first stage was I used an incision in the inner gluteal cleft right here and actually put an implant in this area, and I did liposuction around her body. Added fat to the lateral portion so that we get rid of this depression that's around the side right here. Few years went by. She gained a little bit of weight. I went back in and did a Brazilian butt lift on top of that. So now I did liposuction of her entire body, her lower back, and then added more fat to this area. And the reason I just saw her a few weeks ago was she has gained some more weight, and I just did another Brazilian butt lift on her, but I don't have post-op photos from that. So for those extreme cases, for like the Instagram models that we saw in the beginning, this is my approach to that.
Okay.
Now let me ask you, from the first picture to the second series of pictures, that, just to clarify, that was with a implant?
So this is an implant and fat.
And implant and fat. And so, you know, did she gain? It looks like she gained a little bit of weight from the first series of pictures to the second series. If you look at the thigh position here, you know, particularly the inner thigh, that's traditionally not a place where you would put fat, right? The inner thigh.
That's right. That is a correct assessment. Yes, she has gained weight.
A little bit of weight, yeah. And what type of silicone implant are you using?
So it's a solid silicone implant, which is specifically for gluteal augmentation. Unlike a breast implant, which is soft and supple, gluteal implants are rigid and firm. And so it feels as though you had done a million squats. That hard feeling you get in your gluteus muscle, that's what the implant feels like.
Mm-hmm.
I bet you this. I mean, I know some of my patients, a subset, they would be ecstatic. This is exactly what they dreamed of. But like you said, it took a long time to get there.
It takes a long time to get there. And with weight gain, that's a very astute observation, Pacella, that not only is this the implant, there's some weight gain that happened as well. And I think the interval between these pictures was a few years.
Mm-hmm.
So there was weight gain that happened, then another round of weight gain that happened. And you see that my results with a Brazilian butt lift just get bigger as patients gain weight. Because like you mentioned earlier, the fat doesn't know where it is now. It only remembers where it came from. So if you tend to put on weight in your tummy or your love handles and you put it in your butt, you'll now gain some in your butt. And that's what happened.
So let me ask you guys a question. Let's say a patient came to see you. You strategized a two series operation or a staged operation like this, and you came up with a quote for them. And they said, well, you know, Dr. Rhee, there's a guy off of Route 46 on the strip mall somewhere who he's going to inject silicone into my butt. I don't even have to do this whole fat thing. And he's charging, you know, a quarter of the cost of what you're charging. So, you know, why are you so much different?
First of all, that's very good. Have you lived in Jersey? Because there is a Route 46 and there's a strip mall, and I think there is a guy down there.
Yep, I thought you'd like that. I know Jersey well, bro. I'm from New York.
I'm impressed. The first thing is I actually see a lot of these patients post silicone injection treatments, and it's usually someone in the Bronx for $500 in their kitchen that'll do it for them. And they, some of them are okay. It's a very hit or miss situation. Some of them are okay, and some of them have horrific results. And most of them are ticking time bombs. If they haven't had a problem, they probably will at some point. Some of them have occasional infections, cellulitis, and other things that they have to keep taking antibiotics for. So I have no problem not doing these procedures. If a patient is unrealistic, if a patient is has any other major issue that I feel like I can't make them happy about it, then I certainly don't want to operate on someone where I don't think I could meet their goals in any way.
I couldn't agree more. We all have patients who come into the office who will either try to price shop or decide they want to go to somebody else for another reason. And that's the nature of plastic surgery. It's my goal that those patients at least go to someone who's reputable, who's doing things that are safe for them. Much like where you guys live, Dallas is a city that has a lot of great plastic surgeons in there. So if you're not going to go to me, go to someone who knows what they're doing and it's not going to be unsafe. And then this is another case. Again, patient wants to be really, really big. And I think this is the last case I have. We strategized in this patient doing 2 Brazilian butt lifts to get her to the size that she wanted to. So this looks like a pre-op and a post-op on the right. And it is, but what I left out was the intervening operation to get the size that they want. So to get to this particular size, many times, in order to allow the buttock skin envelope to really expand, you need to do it over 2 operations. And so if the patient's willing to go to do it twice, I'm totally willing to embark upon that. And I think the most I've done on one patient is 5.
Wow.
So, yeah. So there are patients that really are motivated to do this. They just have to know you can't do it in one.
And how much weight gain do you advocate for these patients in between operations?
None. Oh. I just want them to be at, I think what they describe as sort of being their comfortable weight, the weight that they can be happy living at.
Okay.
I think we can find fat if we look hard enough from a variety of places. Mm-hmm. To me, it's less of an issue of the amount of available fat and more of an issue of how much the butt will expand and fat loss that actually is happening.
How much time is the minimum between operations for you?
6 months.
Do you find it's really fibrous and sort of harder to go through the planes to get the fat the second time around, or no, it's about the same?
It can be. And there are some cases where we've used low power ultrasound assisted liposuction because that's going to be an issue. And so, there's a lot of controversy about whether or not you can use ultrasound assisted lipo. And that's not necessarily a conversation for this podcast, but a Vaser at like 30% of its normal power is something that you could actually use and still have viable fat cells for injecting. And simultaneously, it's easier to do liposuction on the fibrous areas.
It's a great result.
Thank you.
Yeah.
So I think that's it. So that's what I have to say about butts today. I'm trying to stop staring. Here we go. Perfect. Okay.
That was really impressive. I think I learned a couple things there that I think I'm interested in exploring in my practice for sure. I feel like with BBLs, the thing that you showed is that one operation you can really make a difference, but it's patient expectation and goals, which are sort of, you have to be able to meet them. And, whether it's one operation or multiple operations or even something that's realistic is something you have to sort of suss out, just like every patient beforehand.
Yeah. And it's tough because a lot of times too, I don't know about you guys, but I find myself competing against people that are, and I'm guilty of this just as much, of the immediate post-operative Instagram result where it's an on-table result and it looks huge. It's just not indicative of how it's all going to settle out. And so every picture I showed is at least 6 months post-operative, which is realistic. The ones I do right after surgery that look amazingly big, they're not going to stay that way, but they still look good on Instagram.
Don't believe everything you see in social media.
That's right.
All right. Awesome. So then the last thing I want to sort of go through with you guys is, and I'll add this, my screen, is this week, Endo International, which is a pharma company, has just gotten FDA approval on July 6th. So it was like less than a week ago for QWO, which is a collagenase Clostridium histolyticum. And basically it is, quote, a new treatment for moderate to severe cellulite in the buttocks of adult women. So that's exactly what it was approved for. So we can talk a little bit about this and sort of what we might expect from it. So let's talk a little bit about cellulite. So everyone knows what it is, I think, but a formal definition is that it's basically an alteration in the contour of the skin. 90% of adult women apparently have it, and it affects all races and ethnicities pretty equally by report. The main cause of cellulite is this fibrous septi, which you can sort of see here, tethering and separating the fat cell volume, which results in this sort of bulging of fat through the skin. And it looks like dimpling and nodularity on the skin surface. And when you look at it, the causes are multifactorial. It depends on how many fibrous bands you have. It's more common in women, mainly because men's connective tissue tends to be denser, so you have less bulging. Also, obviously, the fatter you are, the more volume of fat that you have, and then the thickness of the overlying skin also plays a role, whether you can actually see cellulite. And there are no really good grading systems for cellulite, but they have one where you don't see any dimpling even if you put pressure on the skin. Most people, if you really sort of squeeze the skin, you might be able to force some dimples to appear. And then obviously it gets worse as in the grading system. Not really so helpful, I think, but there are some grades out there so people can sort of assess severity. For our current treatments, I don't know if you guys can chime in. If there are 4 major treatments that I saw out there right now on the market. The first is cellulase. This was the first FDA-approved treatment for cellulite. It's basically a small laser under the skin. The laser heats up, it melts the fat, and also softens the fibrous bands or breaks them. It, by report, delivers a reasonable result, but does not completely get rid of cellulite, and it costs around $5,000 per treatment area. It has a relatively low satisfaction rating that I've seen in patient forums, usually around 20%. Any comments about cellulase from you guys?
It's so slow to do it as the practitioner that the couple times I've done it, I sort of vowed I would never do it again. It's mind-numbingly slow. And same thing, like the results are okay. It's not worth the amount of time that goes into it.
The other one is Z-wave, which is acoustic wave. It basically is a high energy radial shock wave through the probe. It leads to breakdown of the tissue surrounding the dimpled areas and then the collapse of the gas bubbles within the fat structure. It requires 10 sessions done 2 to 3 times a week. Each session's around $300 to $400. I have never seen anyone get this or seen any satisfactory results posted anywhere about it.
So we actually have this technology as well through our skincare center. The nice thing, as opposed to cellulase, it's an in-office procedure, and it can be done with other things. You know, what about Selfina? Do you have any experience with Selfina? Were you okay? So perfect. Yeah. So
talk to me about Selfina.
What I was going to say about Z-wave, you have to have realistic expectations. It's not going to make it go away, but patients will take minor improvements.
Okay.
Selfina, I've never done, but the plastic surgeon who has an office right next door to me, Brad Hubbard, does a lot of it. And one of the busiest guys in the country doing it. Really slick at it, actually. And before and after results, given the fact that it's an in-office procedure that he can do, you know, generally he can demonstrate sort of 40 to 50% improvement in it. So it's time consuming and expensive, but I think it works.
Right. So this is basically a variation of subcision, which I don't know if you guys have done for like small scars or little acne scars, where you're basically taking, in this case with Selfina, you mark the area, you numb it, and then there's a little tool that grips the skin and nips the connective tissue with a little blade. It's the difference between this and say regular subcision is that it's more systematic, and then there's a vacuum that kind of pulls the skin up and stretches it, so it makes the area a little bit easier to cut. It takes about an hour or less, and it's about somewhere between, they said, 2 to 5K per treatment. It got in some of the patient forums, a 75% positivity rate, which is pretty good for something as difficult as cellulite. And then the last one is this RF treatment, Velashape from Syneron. It's basically, they have 2 types. I think there's a liposuction that's RF assisted, and then a non-invasive that's just straight RF. Basically heats the cellulite with radio frequency. Anyone have any experience with this?
I don't.
Oh, okay. And then there's some other non-invasives like endermology and carboxytherapy, which I have not had a lot of familiarity with.
I actually use endermology as our form of lipomassage after our liposuction patients. It's been great for that, but I think as a primary cellulite treatment, it's not amazing. But it's great for postoperative lipomassage.
That's good. So what is Quo? It's collagenase, and we have all we're probably as providers pretty familiar with collagenase. We use it as a topical for wound debridement. It's basically an enzyme produced, it's purified from the bacterium Clostridium histolyticum. It basically dismantles collagen, and collagen is a main extracellular protein that's present in our body. If you've ever done any kind of lab work, like research work with cells culture, you've probably used collagenase to digest the extracellular matrix of cells. We've also used it as an injectable before we had our modern injectables. Zyplast, Zyderm, that was bovine collagen. Cosmoplast was an old human collagen filler that we used to use, but now that we have things like Restylane and Juvederm, those are much less popular. XIAFLEX is the first version of clinical collagenase that was available in 2010. And this was used, this has been approved for Dupuytren's, which you can see is basically the fibrous bands that form in hands, and also Peyronie's disease, which is the fibrous scar tissue within penis, which can occur within a penis, causing curved or painful erections. It is usually caused by repeated penile injury. So I became familiar with Quo a little while ago when investors started being interested, or they became interested in this company. And I started talking about it a little bit with some analysts. In phase 1, they basically had a few volunteers try it, and they seemed to get reasonable results with injecting the collagenase into areas of cellulite. That was back in 2006. Then in phase 2, this was probably about 10 years ago or so. They expanded the study. They had several hundred people, women with moderate to severe cellulite, and they basically started testing different doses and got results which the company had posted on their website. This is all from Endo. And then they just finished up their phase 3 trial. This is their pivotal trial, the one that led to their FDA approval. And basically, they did a multi-center randomized double-blind placebo-controlled trial. They did standardize on the treatment dose, which we'll talk about, and the treatment protocol. And this is sort of their published results in terms of what they felt were what they could get with Quo injections. So Quo itself is thought to enzymatically release this fibrous septi, which you can see here. Basically, patients receive 12 injections per visit per buttock. And then they repeat those treatments every 3 weeks for a total of 3 treatments. The most common reactions, adverse reactions, included bruising and pain at the injection site. They also list as a potential side effect a hypersensitivity reaction, which is pretty common for any drug. This was actually taken from their advertising campaign, which they're starting to market. I love how they use these lifestyle pics like this with people who have no cellulite whatsoever as marketing a cellulite drug. But basically, they have they expect it.
It's aspirational.
It's aspirational, right? Of course, you have to be super skinny and be on a beach as well.
Of course.
So they basically have expectations. This will be available next year in the spring, so spring 2021. They have, based on the XIAFLEX pricing, XIAFLEX, which I'll go back to, basically was about $3,000 to $4,000 per vial. And so and the vials of Quo are similar in terms of amount. So this was 0.9 milligrams, and they're going to have 0.92 milligrams in their vial for Quo, and then a double vial, which is 1.84 milligrams. Based on their dosing treatment schedule, it's going to be about $6,000 for 2 buttocks, so both cheeks per visit. So my guess is they're going to be probably about $18,000 all in for treatment of the butt for 3 visits.
This is just for the cost of the product?
That's exactly right. So this is just for the cost of the product.
But aren't they, I had read that they are marketing it as a different name and a completely different drug, because the XIAFLEX market is an insurance-driven market, and this is going to be the cash pay market. So to me, it's almost like how Botox has got a separate medical and cosmetic arm and different pricing for how you market it, because that seems exorbitantly high for 3 treatments.
Okay, if they charge less, then people could use Quo for their Dupuytren's contracture patients, and who's to say that that's the thing. Are they going to change the XIAFLEX pricing, or are they going to market Quo at a cheaper price? Because I think they're going to cannibalize one of their markets if they change the pricing on one or the other. You know what I'm saying?
No, it's true, but that's why if it's marketed as a different name and a different product. I mean, you see that with meshes all the time, right? There's a breast mesh that we all probably use quite, significantly in our practice, which costs X amount, and then when it's used for abdominal wall and it's got a different name, it's 5X. And so I don't know. That seems like that would limit their ability to grow their market at that price. That's the only reason why I'm saying that.
No, I agree. I'd be surprised if they price it exactly at the XIAFLEX pricing, but how are they going to get away with charging less? What are they going to do with that? I'm not sure. You're right.
I mean, it seems very high of price.
What do you guys think of the results?
Amazing. For an in-office procedure, I think it's fantastic.
Yeah. What would you think be a reasonable price for the drug itself that would actually drive it to market?
Half of that, probably.
I would say a quarter. People equate in-office procedures with low cost, and this is not anywhere near low cost,
I mean, I know that around here, Selfina, which is not this level of result, is $5,000 a treatment. So I think people would spend it if these are not just outlier results, but typical results people are seeing. I think they would spend half of it.
So $9K. So somewhere between what Sal's thinking would be $4.5K to $9K for treatment for these types of results. I think you're probably right. I think there's going to be a black market for collagenase. Let's just put it that way. This is not any different than, I'm sure that there are more stringent safety requirements in terms of producing this drug, but I do know that there was talk of overseas providers already doing this with non-approved pharma grade collagenase. So we'll see. We'll see if this actually proves to be something that's useful. Because I feel like even if you charge that much, if you can fly overseas and someone will take some sort of off-brand collagenase and just inject it, what's the point? Like, where's the market? The bottom might drop out of the market. I don't know.
Right.
All right. Anyway, so that's that.
Well, very interesting, Dr. Rhee.
Thanks.
Thanks for that. That's exciting. I didn't know much about that product before that, so thank you for that. That was very educational.
No problem. I think it's, again, as surgeons, we're sort of insulated to a certain degree from the non-surgical stuff because we always operate, and there are a lot of people that don't operate. There are a lot of people that do all the non-surgical stuff, but we also have to be able to do all the things that we're supposed to do in plastic surgery, which include these types of procedures.
Right. Well, good. I think we're getting past our hour mark, which is usually our cue to stop. So, great show, guys. Thanks for letting me know how you do things and teaching us about Quo, Dr. Rhee.
Yeah, thanks about that. I really appreciate it.
All right, everybody. Well, thank you for attending. Thank you for joining. And once again, don't forget to follow us on Instagram at the above labeled Instagram handles at Sam Jejurikar, at San Diego Plastic Surgeon, and at Bergen Cosmetic. Thanks, everybody. Have a wonderful week.
You too.